or we have a focal flow, like in this region where we picked up a match, there was a focal increased flow, or we have a surrounding flow which is seen. The importance of this is that what we need to understand, although there's a lot of work which is going on Doppler, the sensitivity of increased flow is not adequate to replace biopsy. Essentially, the role of transrectal ultrasound would be in a patient, in a proper clinical setting, would be a biopsy guidance. Just a cursory glance at the prostate with the ultrasound and you don't find up any focal lesions would not really rule out a CA. So the Doppler really is not very sensitive as of now, or rather we don't have the real criteria. Now it's the preferred technique to guide biopsy of the prostate. What we do is what we call as a sextant biopsy. The biopsies can be distributed throughout the prostate in a standard geometric pattern. Usually the surgeons do a digital guided when they just feel the prostate and they shoot, but they really don't know have they really gone about it in a standard geometric pattern. Biopsy is a position on the periphery of the gland where most cancers are located. But practically when we do it, there's a lot of since we have a 15 mm core, and when we shoot, we do have a lot of inner gland also which comes along with it. So it more or less covers the entire thing. Now if you can see out here, the focal lesions can be directly targeted. This is a small video clipping which is showing the needle going right through, and there it's hit the capsule and we shoot, so it's gone in. This is what you see on a post biopsy, the needle going right through. As you can see very clearly from here that it's very easy and simple because you know exactly where you are. Like here on the right side in the mid gland. So you can very easily do it. Another important thing is the risk of damage to midline structures minimized. Very important for biopsy because all the complications that we talk about is basically when there's damage to the urethra or to the bladder. So there is no doubt about it that direct visualization of the prostate taking a biopsy is a far more superior technique. The sextant biopsies include 3 biopsy cores which are about 15 mm, obtained from each side of the midline, one from the base, the midline and the apex. And now we have started taking up to 10 core biopsies. Another 4 additional cores are taken from where we pick up grayscale or Doppler abnormalities. Now the PSA. The importance of PSA, that's objective. It's not very subjective. Ultrasound is always subjective. Whether you have visualized the lesion, you have not visualized the lesion. Whereas the PSA is very objective. Now, what are the criteria? What is suggestive of CA? A PSA of more than 10, but then 4 is normal, 10 is abnormal, 4 to 10 is a gray zone. So then what do you do with those patients? You take the PSA and the weight. The PSA to weight ratio of more than 0.15. Or now currently the thinking is that you need to do a free PSA, a free to total PSA ratio of less than 0.2. But we need to understand that PSA is also raised in hypertrophy, in prostatitis and manipulation of the prostate. So if you have done a TRUS, if you do find abnormality, if you want to get a PSA done, you should wait for about 72 hours before getting it done. Because a prostate manipulation after a DRE or post ultrasound would raise the PSA. You might get an erroneous result. Now, BPH, by far the commonest thing for which usually patients to come with us with an enlarged prostate. BPH can be likened to a fibromyalgia or an involuntary hyperplasia. Something like a fibroadenoma in the breast, something like a fibroid in the uterus, maybe we could broadly just, classify in the same way. It involves the inner gland. It causes compression of the urethra and displacement of the outer gland. Right here we can see the diffuse enlargement, as you can see, of the inner gland. We can also appreciate it out here, and this is of course the transverse section, and you can see the outer gland being pushed out. You can see that the inner gland is slightly equiporous compared to the outer gland, so you can make out the margin very well. And of course at the same time you can evaluate the outer gland also for any irregularities or CAs as we discussed earlier. Cystic changes, these sort of things out here, calcifications, all part of the BPH profile. We don't need to worry about these. Of course, we always have a PSA in the background whenever we are evaluating the prostate, as there is a lot of overlapping features. People who are fond of grading, a lot of surgeons, what grade is it? 1, 2, 3. A thumb rule out here would be the axial diameter. Grade 1 would be a 40 to 45 mm, transverse diameter. 2 would be 45 to 50. More than 50 mm we put it in grade 3. Measurements, traditionally we have been taught of having 3 measurements multiplied by 0.52. But you need to understand that once there is BPH, the prostate is not very elliptical, it's more spherical. A 0.66 measurement is what really corroborates post-operatively what we have seen. A post-void residue of more than 50 cc is significant. Debatable issue, doesn't really matter if the patient is symptomatic. Well, there's an enlarged prostate, we have prostatism. If the patient is not symptomatic, maybe even 75 cc could pass off as normal. We can evaluate the TUR defects. What we need to understand out here that essentially the whole idea of doing a TUR is to release pressure on the urethra. Post-operatively, if the patient still has symptoms, we need to look at this. That is the urethra clear? Can the urine be passed clearly? Or is there incomplete resection of the prostate? What you can see out here is regrowth of prostatic tissue. These are the polyps. Lead to a lot of many problems, but this is what is normally seen on a post-operative thing. Prostatitis, inflammation, lot of controversy again. Is there an entity like prostatitis? It's there. The patient is with perineal pain. We have a lot of features in ultrasound. We confirm them. We give an antibiotic cover, and the patients do usually respond to it, post, sits, bath, and stuff like this. Now, on prostatitis, usually it is caused by UTI. So it's infective, and the infection leading to the inflammation. Periurethral region is ecopoor. This region, ecopoor. As you can see it very clearly, that's the bladder, that's the ecopoor, periurethral region as compared to the rest of the prostate. In severe cases, you can get abscesses of this sort. Slightly difficult to do an ultrasound in this case because the patient has severe pain. But this is very uncommon because now in most of the metros, patients come in very early. Antibiotics are very broad spectrum, so we really don't have a lot of abscesses which come in now to us. Prostatitis, there is an entity which we call as a chronic non-granulomatous prostatitis, in which we have the circumscribed calcification, increased flow in the periprostatic veins. Something to watch when you see in PID, all along the uterus. In the same way in the prostate, we have these veins which are abnormally dilated, and we assume that these are pelvic congestion, which is post-inflammatory, which is giving rise to the pain. Chronic granulomatous prostatitis. We have ecopoor foci in the outer gland. Now look at this out here. Very difficult to differentiate from CA. Again, the PSA bails us out. Periurethral abscesses. You can see these abscesses out here. We see these things because we have tuberculosis everywhere. So we see these things. Periurethral abscesses, lesions of this sort. Now the seminal vesicles and ejaculatory ducts. A brief on the embryology on how the prostatic urethra right out there gives out endodermal outgrowths, these which form the prostate. The mesonephric duct which forms the vas deferens coming in from the testis. Outgrowths out here are the seminal vesicles, and these are the prostate of the vas deferens within the prostate is basically the ejaculatory duct. That's a prostatic utricle out there. Important to know why it's there because you see a lot of midline cysts, so you know it's just a prominent prostatic utricle cyst. The vas deferens, good modality. Ultrasound, non-invasive. We don't need to inject any dyes. We don't need to do it on the OT table. We can easily evaluate the vas deferens out here on a transrectal ultrasound. That's the seminal vesicle, slightly cystic. Vas which is dilated. So we obviously are looking for some sort of obstruction at that point. This is again the right vas deferens, as you can see it grossly dilated. This is another case in which you can again see the same situation. Seminal vesicle is normal. You can see the vas deferens dilated out here, very prominent. Otherwise, very difficult to pick up the vas. Once you see something like this, you know there's an obstruction. Here's another vas out here coming right out there, dilated. That's on the actual scan. Now, seminal vesicles, cysts of this sort, peripheral rim, echogenic rims, calcifications, incidental findings, not very, not very clinically relevant, but they do fall in along with prostatitis. The patients do present with hematospermia, so you do have a clue on what you're really dealing with. Out here, congenital anomalies where you can see absent seminal vesicles, they're just not there. So you know when there's a low fructose semen, a patient is coming to you for a prostate, you don't see the seminal vesicles, you know what the problem is. Ejaculatory ducts. Now look at this out here. Echogenic focus right out there. That's the vas. The portion of the vas within the prostate ejaculatory duct, and out there there's an obstruction. Another one out there, a calculus. These lesions which are there at the terminal ends of the ejaculatory ducts are very easy to treat. Just go in there, do a TUR, do a de-sloughing, and the obstruction is out. The patient really benefits. Another one, as you can see out here, that's the ejaculatory duct coming right out there and dilated right up to the urethra. So very easy to treat. This is of course in the actual section where you can see the calculus out there. On the actual section, this would be the opening of one ejaculate duct. This is the other one. You can see there's a calculus out there. Or let me say there's the echogenic focus, which of course this is showing shadowing, so it's a calculus. It could just be post-inflammatory calcification also. This is again, you can see cystic lesions out there. Like I said, prostatic utricle cyst, ejaculate duct cyst, that's how they appear. Thank you.
Thank you very much, Dr. Rahul, for finishing such an excellent lecture in time. Any questions? Our next speaker is Professor Dr. Safdar Ali Malik. He is one of the most popular radiologists in Pakistan and is the professor and head of radiology department, Fatima Jinnah Medical College, Lahore. He is the life member of Radiological Society of Pakistan and member American Institute of Ultrasound in Medicine. Professor Safdar Ali Malik has presented more than 50 national and 12 international papers in ultrasound. He is a regular speaker in mental health program in special education teaching and training program, which is held in Lahore. He has also participated and published